Again, notice how it wants to scroll following exposure to the humidity, and using the curved forceps, the amnion is spread out and flattened on the cornea. It's then left to dry for a couple of minutes, and during this time, the bandage contact lens is dried meticulously as well, and it will be placed on top of the amnion. No sutures needed. Patient did fantastic. We've recently identified one case where the amnion seems to be absorbing slower and perhaps integrating into the cornea itself. This is a patient which received amnion for a persistent epithelial defect after cross-linking, and this is 1 month after the amnion. We speculate that this may be the result of placing the amnion with the stromal side facing down, and we do advocate always placing it with the stromal side facing up. And you can identify the orientation with the AmnioTek by looking at the thicker and thinner pieces which stick out, which help you understand what the correct orientation is. Eventually, this did absorb completely, but just took a little bit longer. So you do want to try to maintain the correct orientation when you can. In terms of expanding indications for dehydrated amnion, we've started to use these prophylactically, so to speak. For instance, we've had 2 cases of patients with neurotrophic keratopathy and a secondary band K. In those cases, following a superficial keratectomy combined with EDTA, we applied the amnion at the end of the cases to improve regeneration of the epithelium. These tend to be very slow healers, and in both cases, following absorption of the amnion within 2 to 3 weeks, there was no epithelial defect left. In addition, we've had 2 cases of patients with bullous keratopathy and blind eyes referred for recalcitrant pain. In these cases, we offer patients epithelial debridement combined with anterior stromal puncture and a diamond dust spur, where we're intentionally trying to scar the anterior stroma, and we follow this up by placing the dehydrated amnion to improve healing. In 2 cases, we had complete resolution of symptoms, and in the third, partial resolution. Finally, we've used this prophylactically in 2 cases of patients undergoing epithelial debridement for recurrent corneal erosions. The reason being is that there were concerns about their healing due to background insulin-dependent diabetes. So you can clearly see the expanding indications for dehydrated amnion. This is a nice take-home slide regarding all possible modalities when it comes to ocular surface optimization. This includes lubricants, anti-inflammatory options, nutritional support, lid margin management, and adjuncts such as amniotic membrane, which are covered in this talk. And a few take-home points. Use earlier prior to scarring for cases with persistent epithelial defect. Don't wait to use it. This is a quick procedure that does not require any sutures. The lack of necessity of sutures means less follow-up visits for the patients, which is a huge advantage in the COVID era. There's faster return to vision compared to a tarsorrhaphy or an amniotic membrane from the eye bank, which is quite thick. And a few tips: I do recommend taping the patient's mask meticulously to avoid humidity during the procedure, drying the cornea surface as much as possible to avoid curling of the disc, as mentioned several times in this talk. Again, thank you very much for tuning in. Hope you enjoyed it, and thanks for Jay for inviting me.
Thank you, Michael. Thank you very much.
My pleasure.
That was great. So enjoy your meeting at the ASCRS. Thank you for coming. And that was great.
So my job today is to show you how to use dehydrated amniotic membrane as an in-office application, which is fairly straightforward and simple. Can everybody see the slides?
Yeah.
So we've used
Okay.
We've used amniotic membrane, dry amniotic membrane in the office for more than 20, 25 years. It's been done by both the ophthalmologist and the optometrist. In fact, I'm a little embarrassed to say this, but the optometrists have done more than the ophthalmologists, and they're probably pretty good at it. And as you heard previously, it's really beneficial for any persistent corneal defect that's not healing. Abrasions, erosions, dry eye, infectious sterile ulcers, chemical thermal burns, limbal cell diseases, neurotrophic keratopathy, and even some deeper ulcerations. And it's, again, simple and effective, and we can do it in the office. Next slide. Can you advance me, Jay? Or do I?
Yeah.
So really all you need is a lid speculum, a non-tooth forceps, and a soft bandage lens, preferably a large diameter, what we call a contour contact lens. We put in the anesthetic drops, as you saw previously, put on the lid speculum, take out the amniotic membrane, apply it over the defect, usually concentrically. And really your best bet is when you first lay it down. You can't lay it down and try to lay it down and try to pick it up again. It really just sticks down as soon as you get it. You want to try to smooth out the wrinkles with both the forceps and either a wax cell or a cotton tip applicator. Then we put antibiotic drops in. As you saw previously, we add the contact lens over that. Next slide. Jay, do we need to show this? Because Mike had a pretty good video on it.
Go real quick.
All right, go ahead. This is a video from Dr. Jarapodi from Thailand. Sorry about the music.
Yeah, sorry about that.
So again, it's an in-office procedure. The membrane is rather friable, so you want to grab it with non-tooth forceps. And I'll tell you about the orientation on the next slide. You can also do this at Philamp as well. Membrane's been applied, that's the bandage contact lens, and essentially it's done.
So that's it?
Yeah. So again, a couple important points to remember. Remember one or two points today. Once you lay down the dry amniotic membrane, it adheres immediately to the cornea, and it's difficult to move afterwards. So you really want to make it concentric to the center of the defect, and you do want to kind of take out the wrinkles with the forceps and the contact applicator. Again, it's very friable, lightweight, although you are going to get the thicker version, hopefully. And the proper orientation is very important for the epithelial defects. You want the small tab at 12 o'clock and the large tab at 3 o'clock. Again, the small tab at 12 o'clock and the large tab at 3 o'clock. And you can also cut and fold and apply multiple membranes on a deeper ulceration as well. Next slide. So again, that orientation, smaller tab at 12, larger tab at 3. That's how you know it's epithelial side down. It's really not good to patch over these eyes. You really have to put the bandage contact lens for the most comfort, and so patients can ambulate and return to work. The dissipation of the amniotic membrane is variable. We've seen it dissipate anywhere from 1 to 7 days. Don't forget your antibiotic therapeutic drops. And we find that a couple of things, that it promotes healing and reepithelialization, as you saw on the previous slides, reduces scar formation. And recently we've shown that we've done 60% less tarsorrhaphies as a result, because our tarsography is essentially our go-to last, surgical technique when nothing else works. So that's been pretty impressive. Thank you.
Thank you, Dr. Wilson. That was great. Thank you very much.
Good evening. Assalamu alaikum, everyone. Good evening. Yeah, I just will open it now. Is it?
Yep.
Is it on now?
Yes.
Okay. Good evening, everyone, and thank you for the invitation. So my talk will be about amniotic membrane practical application in general. As my colleagues mentioned about amniotic membrane, just the inner layer of the placenta consisted of a thick epithelium with a vascular stroma. It lacks immunogenicity, so there's no reaction to the amniotic membrane, and that's the very important property of the amniotic membrane. And it had many properties: promote epithelialization, antifibrotic, anti-apoptotic, and anti-agenistic, so prevent the blood vessel formation. And it used in wide specialties, not only ophthalmology, but also people start the dermatology and burn. They're using a lot more than us, really. Regarding mechanism of action, it's the base membrane. It's really similar to the
Dr. Osama, can you unmute yourself?
Okay.
Yeah, good. Thank you.
I'm not sure because it went off, and then so going back, so the mechanism of action is because the property of base membrane is close to the conjunctiva, and also it has the suppression the microfibroplasis, so prevent the scar formation and vascular formation, and promote healing because there's a lot of cytokines, a lot of growth factor available in the amniotic membrane, help us for clinical use. Is moving now? It's okay.
Yes.
There's three ways how the principle governing the using amniotic membrane in the eye. It can be used as inlay, whereas the amniotic membrane is formed as scaffold, allow the epithelium to grow over it and incorporate it in the host tissue. So this is for cornea or conjunctiva. And for this technique, we need to have the base membrane side up, so it will stay. And that usually, if you want to have a small area of melting, you want to keep this, and that you use this one, or you can use it like for bullous keratopathy, so you have incorporated that one, and that's that technique is as a lay. The other one, which more commonly used, what you call overlay or batch, whereas the amniotic membrane using as biological contact lens to promote the healing, and usually that's epithelium side down, so it doesn't stick and tends to fall out by itself, or we remove it. And the other way, the other technique, where we're using amniotic membrane like layers, where there's a gaps, we fill the gaps and overlapping it, like it's for very thin cornea where you want to incorporate some of the amniotic membrane to it. Then nowadays also some people using for macular hole, like as overlay, filling the gap. Regarding how to fix the amniotic membrane, either using bandage contact lens, that's my colleague show you all using just simple put amniotic membrane disc, put bandage contact lens over it. But you could also suture, but absorbable or non-absorbable, or you could using what you call biological tissue adhesive like fibrin glue, which is also very useful to fix that amniotic membrane. Indication we're using very widely in a lot of ocular surface disease, pterygium excision in the form of limbal stem deficiency, persistent epithelium defect, bullous keratopathy, corneal ulcer, or recently, as I mentioned, some people using in macular hole repair. In pterygium, usually it's we're using for very bad pterygia where you don't have much conjunctiva available, or someone had the glaucoma, you want to save the conjunctiva, or you had the valve, you don't want to disturb it. But generally for pterygia, the primary object is better to use a conjunctival autograft. But if you cannot do that, the amniotic membrane is a very good alternative option to prevent the recurrent. For ocular surface reconstruction, like symblephrone, if someone has the bad symblephrone, it's very useful. If they had conjunctival chalasis, redundant conjunctiva, it can be another modality. It can be used for as a treatment, but is really widely used for any surgery involved conjunctiva and corneal tumor surgery for reconstruction. It's covered the area where you remove the conjunctiva, but also promote the healing and prevent the vascularization and prevent scar. So it's very useful in a lot of ocular surface construction. Regarding stem cell deficiency, it can be used for total or partial, but for total, remember the amniotic membrane, there is no stem cell, so it's promote healing. So you need to use in conjunction with allogenic stem cell transplant. And some people now use the amniotic membrane to grow the stem cell in the laboratory. So it's using as the membrane as a scaffold. So you grow the stem cell over it and you put it over the cornea in the very severely damaged cornea with the gross stem deficiency. But also for partial stem cell deficiency, you could remove some of the stem epithelium, conjunctival epithelium involved the center vision, and you use amniotic membrane to promote the healing and visual recovery. This is one of the cases a long time we did in UK, where this patient had severe alkali burn. So we had cornea graft, but he had also keratolimb allograft, and use amniotic membrane to promote the healing and allow the eye to settle after the surgery. This is after first month and the bottom one after 6 months of the surgery. This is another one patient who had the severe alkali burn done by my colleagues that time when I did fellowship in East Grinstead. She was died. It's very bad alkali burn with a lot of symblephrone, and so the patient had keratocornea, limbic cornea graft with this amniotic membrane, and this is 2 years after the surgery. So it's very useful for complex cases where you to allow to promote healing and prevent fibrosis. There's a new technique nowadays published by our colleagues in San Juan in India, which is a simple technique for stem cell transplant, what you call simple limbal epithelium transplantation. Really, so basically we've taken the stem cells from the other eye if it's normal, if it's uniocular, like a burn or something, or using from the donor, and take a small piece of the stem cells, limbal area, and make it small pieces. And then in the patient itself, do large periotomy and cut this small piece of stem cell around it, avoid the visual axis, and cover it with amniotic membrane. And that's really very good way to culture using stem cell culture in the patient eye. It's very economic, and he reported many cases really with a very good successful for a big stem cell deficiency patient. For bullous keratopathy, you could use what like Michael say, you remove the epithelium and you do diamond or anterior stroma puncture, or you could do another one also. You could remove the epithelium and you use the basement membrane up. So you want to just keep this amniotic membrane integrated in the eye. So the normal epithelium of the patient grow over the membrane. So the membrane become like a barrier, prevent the bullous and prevent the pain. And this usually we do it for patients who there's not good for cornea graft because visual potential is very poor. And so it's very simple technique, but most of very common in our practice nowadays, we had a lot of what you call persistent epithelium defect. Either we did BRK, corneal cross-linking, or could be from neurotrophic ulcer, Steven Johnson, ocular cicatrician bifurgoid, or even severe dry eye. And really very simple technique to promote epithelium healing because of the protection as bandage contact lens and the growth factor. But also remember, when you had persistent epithelium defect, you need to include all other modalities to help this patient to recover. One of them is very important to consider: avoid preservative drops, plasma drops. You could use doxycycline to prevent melting, vitamin C. That's all modality will help you to promote the healing. This one of our patients, I did it 3 months ago, is a very rare case, what you call cystinosis. She had multi-cystinosis in cornea and all her body, and she had very bad keratopathy. Other eye she had cornea graft everywhere else, and it's failed. So just I want not to do cornea graft. You want to don't do aggressive for her because she did badly with other eye. So I did EDTA, BTK, and AmnioTek after the surgery. This is a picture after 4 days with AmnioTek, and really she did very well. I know it is not completely cured for her because she still had a lot of cystinosis in the cornea, but it saved her, give her some vision without compromise her. The other modality we're using amniotic membrane is what we call recurrent corneal erosion. And really is very helpful, and you could use the Brochera or dry cryo preserve amniotic membrane. Both is very useful for recurrent corneal erosion. Regarding corneal ulcer, you could use it for infected or sterile corneal ulcer, where the corneal ulcer is very thin and the risk of perforation, to just promote the healing and stop necrotic of the corneal ulcer. And it could be temporary until the eye quiet and you do corneal graft. But if it's periphery, it could be a permanent solution as a treatment to save this eye without the need for corneal graft. Stephen Johnson, this is another case where Stephen Johnson, which have melting in the periphery, and she had a small batch amniotic membrane covered with the larger one. So it's two layers. One is for the melting, and other one by wider corneal graft to promote the healing and improve their dry eye. This is another one. We had batch amniotic membrane with secondary to herpes simplex keratitis, with very thin area. For ocular surface burn, we could use it for either heat-related or chemical-related burn, and really is very effective way to reduce the pain, reduce the inflammation, and also prevent fibrosis and neovascularization. So if you do it early, you could save this patient to go with severe stem cell deficiency and the problem later on, and a lot of symblephrone and damage to and more severe dry. So if you had a bad case of burn, it's really good to use amniotic membrane. If it's wider burn, you need to cover all the eyes. But if it's just the cornea, you could use this amniotic membrane with the contact lens patch over it. The glaucoma, some people using for when you have the tube exposure, although scleral patch or pericardium, it's better if you had availability of that. And some people using for repairing of leaking from the bleb, but also if you had a good conjunctiva, maybe you could consider the conjunctiva. But if it's fibrosis, then amniotic membrane can be a good option for this patient. A neurotrophic pain, we had few patients now coming up, especially after laser surgery. This one patient had LASIK surgery, had the neurotrophic pain. And I use this one, this is a Brochera Slim, but I think AmnioTek also, they have a new one with the hole. So basically that the patient, you want to keep his vision still there, because when you put the membrane, that will vision be blurry until the membrane dissolve, which is 2 weeks. So it's good to have a clear one in the center for such patient where the problem is not in the center of the cornea, so you could preserve their vision. Risk, as you know, we always worry about risk of infection, disease transmission from the donor, but as we know now, all our amniotic membrane taken from a patient going under cesarean section, and all patients tested for infectious disease, hepatitis, HIV, syphilis. In UK, we don't give a fresh amniotic membrane anymore. We have to test the donor 6 months after the donation to make sure he didn't catch the disease while still in the latent period for the test. So we store it for 6 months, then we release to be used. Conclusion, amniotic membrane is very effective way to promote and healing and as a protection. Is very simple to use, and it can be used for a wide ocular surface surgery. It's very safe and it's really very easy available. So don't hesitate to use it earlier if you had someone had persistent epithelium defect or very severe dry eye. It's very simple, safe. So it helps to patient to recover quicker. And thank you very much.
Good evening, friends. Before I begin, I'd just like to greet everybody, Ramadan Mubarak. May you have a peaceful Ramadan. And I'd like to thank Jay for this wonderful opportunity to participate in this very educational meeting. And I'd like to talk about the range of applications of dehydrated amniotic membranes. The previous speakers have done an excellent job in describing the features of dehydrated amniotic membrane. So I won't go into a lot of details, but I'd just like to highlight that when I started my practice, we were using the cryo-preserved amniotic membranes. But because its access is very limited, it's hard to harvest placental tissue, and it's also hard to store it and access it. For the past 10 years, we've been using the dehydrated amniotic membrane which is very easy to transport. We have 3 clinics and we store some in each clinic so that if a patient walks in at any time with the need for amniotic membrane treatment, we can easily apply it on the spot. It's also very comfortable. There's no need for suturing. So patients appreciate the comfort they received after you apply the amniotic membrane. So I'm just going to go through some of the different applications of amniotic membrane that we use in our practice. The most common indication is for ocular surface disease. And Dr. Osama has very well described the range of ocular diseases where you can use the amniotic membrane on. This is our technique for using it. We like to do the keratectomy or epithelial debridement, which enhances the stickiness of the amniotic membrane. You don't have to do this for every case, but for cases where you believe that the amniotic membrane might get displaced, or if the epithelium is already very diseased, it only takes a few seconds to remove that epithelium under topical anesthesia. And we can use a dual blade lid speculum to keep the eyelids away from the ocular surface. And you just use a simple forceps to lay it down very nicely and centrally on the cornea. And then you apply your bandage contact lens over the amniotic membrane to keep it in place. And be careful when you remove the lid speculum that you don't displace it. So you can kind of use, in this case, a rolling movement as you remove the lid speculum. So just kind of roll it against the eyelids on one side and the other side. You can also use the amniotic membrane without applying lid speculum. So some patients, they find the lid speculum uncomfortable. This is the amniotic membrane AmnioTek C Vision. It has a little hole in the middle. So for patients who have only one eye that's seeing, you can apply this on the ocular surface with the hole centered on the pupil. And you can see here, we didn't use an lid speculum. And if you can align the hole against the pupil, then the patients are able to maintain decent vision when you apply the amniotic membrane. Otherwise, if you use the one without the hole, I normally tell patients they may go through 2 or 3 weeks of somewhat blurry vision before the amniotic membrane dissolves. So at least with the AmnioTek C, they tend to have a little better vision and they're able to function if the patient only has one good eye. These are the range of indications for amniotic membrane application in our practice. And the most common indications have been well described by Dr. Osama, Dr. Michael, and Dr. Wilson. Usually we use it for a dry eye, persistent epithelial defect, bullous keratopathy, also for filamentary keratitis. After we do edtouchylation and removal of calcific band keratopathy, the patients are much more comfortable when you apply the amniotic membrane. You can also use it post corneal transplant to aid in wound healing and other diseases which can disrupt the ocular surface. Now, besides ocular surface conditions, we also use it in some other conditions which I'll describe later. So here are just some illustrative cases. This is a male who had a chemical injury. When he came into the clinic, he couldn't open both eyes. So we applied the amniotic membrane, and within a few days, he had recovered his comfort and vision, and he was able to go back to work. Here's a patient with filamentary keratitis, where despite removal of these filaments, they kept coming back and the patient was uncomfortable. So we did the epithelial debridement, and then we applied the amniotic membrane with a soft contact lens. And a month later, we had removed the soft contact lens, and the patients had a very nice, pristine ocular surface. Of course, all of these, the complete management of this also involves medical treatment. So for these patients, you have to give the appropriate antibiotics or anti-inflammatory and lubricants, not just the amniotic membrane. Here you can see a post-corneal transplant patient who developed a non-healing epithelial defect, and the use of the amniotic membrane with a bandage lens facilitated healing and return of patient's vision as well as comfort. And here's a patient, an office worker who's on the computer the whole day or probably even some of the evening. And you can see the florid SPK before amniotic membrane application here on the left. And 1 month after removal, the patient's SPK had resolved and he had good vision. And this patient was encouraged to continue aggressive lubrication even after she regained her eyesight and comfort. Here's another patient with pseudo-phakic bullous keratopathy with a non-healing epithelial defect that you can see here on the right. So a month after application of the amniotic membrane and removal of the contact lens, the epithelial defect had resolved and the patient, while still unable to see, was now comfortable. So there are many other applications we can show you, but we just wanted to emphasize it's not only return of a patient's comfort, but you can also help the patient's vision recover. So in this patient with recurrent corneal erosion, you can see here on the left image, the total higher order aberrations for this patient was quite high. And because of that, the patient's vision was quite blurred. But after applying the amniotic membrane, you can look at this image here on the right. The total higher order aberrations of the cornea had now improved from 0.9 to 0.2 with return of functional vision. So it's not just a disease that can help the ocular surface heal, but can also restore the patient's eyesight. Here's another image of an eye with higher order aberrations because of ocular surface disease. You can see here the pentacam had measured a 0.5 higher order aberration, but after application of the amniotic membrane and removal of the bandage lens, after a month, this had improved to 0.126 with restoration of functional vision. So aside from restoring comfort and vision in patients with ocular surface disease, we also use it extensively, and it is now standard for us to use it for pterygium surgery. And I suspect that in Libya, with a lot of sunshine, just like here in the Philippines, you see a lot of these pterygia, and you probably do a fair amount of pterygium surgery. Now, you know that if you just scrape off that pterygium, you have a very high recurrence rate. And some measures to prevent recurrence will be using mitomycin C and conjunctival autografts. But it takes some time to harvest that autograft, and you have to apply it over the area with the pterygium. But now you have created a defect somewhere else, and our glaucoma colleagues are not very happy if these patients with a conjunctival autograft eventually wind up with glaucoma and have to see them for surgery. So as much as possible, we want to avoid harvesting autograft to preserve the conjunctiva. So instead of autograft, we've been using the dehydrated amniotic membrane. And in this way, you can apply it over the bare sclera and over the epithelial defect where the pterygium used to be. And you can fixate this amniotic membrane just by putting these conjunctival wing sutures, usually 2 of them, and then we apply the bandage amniotic membrane. So when you do this technique, the advantages are the amniotic membrane over the bare sclera has immunomodulating properties that prevent excessive healing and scarring, and decrease the incidence of pterygium recurrence. And by applying the amniotic membrane over the epithelial defect after you remove the pterygium, you enhance patient comfort. And by putting this amniotic membrane, you don't have to suture by putting the bandage contact lens, you don't have to suture the amniotic membrane. And if you do it well, you can actually use the bandage contact lens to cover the two nylon 10-0 sutures, which also decreases foreign body sensation. So we find that using amniotic membrane for pterygium excision has several advantages. One, you avoid the use of conjunctival autograft while maintaining a low rate of recurrence and giving the patients ocular comfort after the surgery. So our recurrence rate over the past 8 years, we had 3 recurrences in 50 eyes. So that's a recurrence rate of about 6%, which we believe is on a par with using conjunctival autografts. You also lessen the patient discomfort, and we believe that it's a very useful adjunct for pterygium surgery. Now let's move further back into the eye and see how else you can use the amniotic membrane. So I'm not a glaucoma surgeon, but we do have some colleagues that use it for overlaying the glaucoma drainage device and glaucoma drainage device tubes. And they also use it for bleb revision. So one of my friends, Dr. Robert Lewecker, was kind enough to show this video of using the amniotic membrane to cover the AMED valve tubes. So you can see here we use the AmnioTek G, which is thicker and larger, and you can fold this into several layers and apply it over the AMED valve tube. So instead of using pericardium or scleral tissue, you can use thick amniotic membrane, AmnioTek G, and then you apply fibrin glue, and then you can seal the whole thing without the need for sutures. And you can see that the valves are nicely covered. So this is both a fast and comfortable procedure to use. And going even further back, we have been using amniotic membrane to treat retinal diseases, particularly macular holes. Now, as you know, macular holes is a potentially blinding disease that can affect your central vision, and it's only treatable by surgery. There is a significant hole closure failure rate depending on the size of the hole and the etiology of the hole. And retina surgeons have been using different adjunctive maneuvers to increase the rate of hole closure. More recently, using internal limiting membrane flaps. You can also use autologous blood, or you can use a retinal transplant using autologous retina, and amniotic membrane plugs or patching. This is a 71-year-old female with 3 months progressive blurred vision due to a lamellar macular hole. And our plan was to put in, to do the macular hole surgery and to use an internal limiting membrane flap to enhance our success rate. Unfortunately, during the surgery, we had inadvertently removed the flap. So now that we don't have any more ILM, we decided to use amniotic membrane instead. So we stained the amniotic membrane with the trypan blue color, and then we use retinal forceps to apply it into the eye after doing fluid air exchange. And we lay this amniotic membrane on the surface of that fluid, and we can use the forceps to position it over the macular hole. You can also use soft tip cannulas to do the same thing, and you can also use soft tip cannulas to maybe push in part of this amniotic membrane into the hole. And afterwards, this post-op picture shows you the amniotic membrane overlying the hole. And we did post-operative OCT showing this pigtail sign indicating that the amniotic membrane has covered the hole. And this patient's vision improved from 2100 to 2040. We've done this now in 12 cases, and we don't do it routinely, but we use it for patients with large macular holes when we inadvertently remove the IOM flap. If you have to repeat a macular hole surgery where the first surgery failed, in macular holes that are post-traumatic, and in eyes with pathologic myopia with macular holes. One of the most challenging cases to repair would be retinal detachment in the presence of macular holes and high myopia or pathologic myopia. The failure rate of this procedure is significantly higher than routine retinal detachment. So here, what we do is after reattaching the retina and doing fluid air exchange, we would put in this eye with a very large macular hole, amniotic membrane patch, and then we hold this patch in place with a drop of autologous blood. You can see here the macular hole covering this, being covered by this very large piece of amniotic membrane. And this patient had successful surgery and was able to recover vision from hand motions to 2400. So in conclusion, dehydrated amniotic membrane demonstrates excellent biocompatibility, whether it's placed on the ocular surface or inside the eye. It is easy to use, it's readily available, you don't need any special storage conditions. Placing it on the ocular surface lessens discomfort, promotes healing of the cornea, and an improvement of vision. Using it for pterygium surgery results in low recurrence rates and post-operative comfort. You can also use it to promote macular hole closure, and there are also some glaucoma indications. So thank you very much for your kind attention.
Thank you, Dr. Harvey. Thank you, Dr. Osama. Thank you, Wilson. And thank you, Michael. Those were great talks.